Hello and welcome. My name is Nick Davies and I'm a Programme Director here at the Institute for Government. On behalf of the Institute and the Health Foundation, thank you very much for joining us for today's discussion on what the government can do to help improve how the NHS spends money. And it's a great time to be having this conversation. Next week, the government will be publishing the results of its first spending review, which will set departmental budgets for the rest of this Parliament. With spending on the NHS set to be around £200 billion a year and performance still pretty slow to recover after the pandemic, it's not surprising that ministers in the Treasury and DHSC alike are thinking about what they can do to improve NHS productivity. That means supporting frontline providers to spend their budgets more effectively and allocating budgets more effectively as well. That's vital both to improve the quality of services, ensure the NHS is financially sustainable, and make best use of taxpayer money. So what lessons are there from previous attempts to improve NHS efficiency? What options does Wes Streeting have to drive through reforms? What effect, if any, will the abolition of NHS England and the cuts to integrated care board budgets have? And what improvements in productivity and health outcomes can technological developments actually deliver? To discuss those questions and more, I'm delighted to be joined by a brilliant panel. We have Caroline Clark, who's Regional Director of the NHS in London, Anita Charlesworth, Senior Economic Advisor at the Health Foundation, Rachel Sylvester, Political Editor at The Observer, and Helen Buckingham, Chair of Trustees at National Voices. Each of our speakers is going to make opening remarks. I'll then ask a few questions before opening up to questions from the audience. If you are watching online, please do start submitting your questions now using the Slido Q&A function. Right, without further ado, I'm going to hand over to Caroline.
Right, good morning everyone. Horrible to start.
Sorry.
Particularly I'm in a room of people who know a lot about health policy. So I am originally a kind of health service manager and an accountant and an economist. So I'm quite practical. So I'm not going to get into a sort of spiral of productivity doom, which is kind of what we often do. And we talk about measurement. I'm hoping that you lot will, actually, because I think you'll be better at it than me. But as a hospital person, having managed hospitals during COVID, I can remember one of my team putting a slide up and saying, it was a slide of Everest, saying more people either die or get injured on the way down than on the way up. And her point was, whatever we change now, it's going to be much, much harder to get back from. And God, she was right. So I can see the problem. And this isn't that, clinicians have suddenly become lazy or developed golfing habits or anything. We are just finding it harder to get back to where we were. I want to look at productivity in the future and think about, this government's commitment to the sort of left shift of care out of hospital towards prevention rather than treatment and towards digital rather than analogue. And I want to think about productivity in that context. And I've got a kind of sort of four-part manifesto. Before I talk about that, though, I suppose I wanted to just say one thing about unwarranted variation, because that is the thing that drives productivity down. And if we do different things to patients in a non-standard way and we don't have clear standard processes where they're warranted, we drive variation, we drive cost up and we drive quality down, and often our patients don't like it. So we've got to think about unwarranted variation, and whatever we do to enhance productivity has to have, for me, that I have a very strong bias towards driving unwarranted variation out. So those of you that know the NHS will know about GIRF, the Getting It Right First Time team. They're really good at highlighting that. What we're not so good at is having operating models in the health service that actually support collaboration, partnership, and allow us to see where that variation is and, where it's appropriate, drive standard process. So that is a big thing that we need to do more of. My manifesto, though, has got four things in it. The first thing are words to government, and I think we'll see this in the spending review, is around actually make it easier for us to do business with by giving us longer-term allocations. And I think we'll see that, so probably this isn't quite a hard thing, but make it easier for us to have the conversations around technology investment versus bricks and mortar. We've not got that right. We're having those conversations in a very short time scale, and we need to do it over a longer period. Make it easier for businesses to actually stay with us in the UK rather than going off to the States once they've done all the hard work. And that's a really, really big thing for me. So that's thing number one. Thing number two, I cut my team teeth in the early 2000s in the foundation trust movement. I worked at the Homerton when it became a first wave foundation trust, and there is something about incentivising all parts of the system, not just the hospital part of the system, to do more and do stuff differently, and that sense of earned autonomy. You know, people that run health services are generally really good, and they want their autonomy, they want to earn it. So I sense a return to some of that. We need to do it in the 2025 context where we're trying to do the left shift, but I think that's really important. Let's as well as that capturing the standardisation where it's helpful, let's also make sure we're population specific and allow local teams to invest differently. Third thing for my manifesto is let's invest in obvious tech. There are so many technologies in other industries and starting in our industries now that we just need to invest in and make it easier. So in London, we're doing a lot of work on ambient note-taking, ambient voice technology. That has the effect of both allowing clinicians to see more patients in their clinics, but also kind of actually making it a better experience, because no longer am I taking a note at my computer, but I'm also actually talking to you, my patient. So let's invest in technologies like that. Let's invest in technologies where actually the WHO say we're going to be 10 million clinical professionals short globally. Let's invest in technologies that actually start to address some of that problem. And let's do it really intentionally. The benefits don't come by magic. So we have to train our staff to actually do this really, really well. And I think we can do that. So that's my third thing, invest in obvious tech. And there's loads more we can talk about. And my fourth part of my manifesto is let's invest in data. So if we're going to really understand unwarranted variation, we need really, really good data. So the NHS has made a massive investment nationally in a federated data platform. In London, we've also made big investment in data for research purposes. Let's make that really easy to access so that people want to come and do their research in the UK. And let's make hospital and out-of-hospital data really easy so we can see where patients are being treated in real time and do that really well. And then in order to make that work, actually, people like me in my 50s probably need a bit of training to do that. So there's something about making us all digitally literate and really not forgetting that our staff are our best asset. That's my manifesto.
Fantastic. Anita?
I should mention that I'm acting chair of an ICB in London, and so Caroline is my boss. So I agree with everything that Caroline has said, for the record. We at the Health Foundation have set up a commission to look at NHS productivity, and I'm co-chairing that with Tara Alice, and we've been looking initially at some of the learnings from other sectors of the wider economy, because it's very easy often to have a lot of health exceptionalism, and you know, health has some unique characteristics, but there's actually a lot to learn. And undoubtedly, the pandemic led to a major drop in productivity, I mean, up to 25%. And whilst that's really significant and really important, the thing that we're very focused on and I'm really worried about is not so much the recovery from the immediate hit of the pandemic, but that what happens after the pandemic is we get stuck in a low productivity equilibrium. And I'm worried about that because in the wider economy, after the global financial crisis in 2008, that's exactly what happened to our economy as a whole. So shocks are really important for the impact of the shock in the moment, but actually the big worry about any shock is that you can get stuck then in a very suboptimal place. And it seems to me that just as in the wider economy, without really paying very close attention to that and thinking about how you avoid getting stuck, you know, and the effects of being stuck in a low productivity equilibrium for our economy over 15 years way exceeded the initial hit from the global financial crisis. So that seems to be something that we really need to think about. And I think, again, looking at the wider literature then, the challenge, therefore, is both to obviously focus on the immediate recovery, but to really think through then, how do we get to a system which in which productivity improvement is hardwired in. And that's not finding individual initiatives, but really thinking through what are the mix of enablers and incentives on a stable place, which collectively ensure that the NHS has the incentive to look for the productivity opportunities, and then is able to mobilise those really effectively. And it's very hard from Westminster to pick what those things are, and certainly in a period of change, very hard to get ahead of that. But we need a system that is able to do that dynamically. And the evidence from the wider economy, and I think which holds very true in healthcare, is therefore that there are 4 things that we really need to look to. One is capital investment. You know, we are an undercapitalised health system, undercapitalised NHS. Caroline has just given some really clear examples of that. The second thing is obviously workforce. We go through cycles of boom and bust on the workforce. The result of that is actually, you know, through the pandemic and beyond, we've had a big increase in staffing, but we get these big influxes then of inexperienced staff. If most of us in the organisations we're working in had 20% more people turn up next week, we would be less productive for a period, not more. I mean, that's the reality. And then you go from that to massive cuts. No one can run effectively then. And then, of course, it's not just how many people we have, but we need to work effectively in teams within organisations, and most critically across organisational boundaries. And we need to get the right people with the right skills in the right sectors, and that changes over time. So the workforce challenge is hard. The third thing then is innovation, which is both the system we have to support innovation, which is tech innovation, but also process innovation. A lot of the things like GIRFT are about how we do things. There's an enormous amount in know-how. All of those things are really important, but actually what matters is getting them in balance and optimised across the tree, across different parts of the health system. And in the private sector, we think of competition as the way in which we do that. And over the last 20-odd years, one of the questions in the public sector is, what's our equivalent? And in the 2000s, obviously, governments went for new public management, quasi-markets, and there was a very coherent, you can argue about whether it's right, but very coherent programme. The public services fell out of love with that, but nothing was really put in its place. So we have quite a confused system. And one of the key questions, I think, and perhaps why this 10-year plan for the NHS is taking a while, is that different people have different views about what those systems are. And my main plea is that whatever comes out is that it is coherent and all the incentives and the enablers point in the same direction. OECD did some work over a decade ago now about what makes effective healthcare system. And they said, actually, there are different types of ways you can run your health system. You know, and broadly speaking, you know, there is no one system which in and of itself performs much better than another. What matters is how coherently you've organised the system that you have. So the most important things are stability and coherence in whatever we do.
Thank you. Rachel.
Thanks, Nick. And I agree with everything Caroline and Anita said, obviously. The thing that I've got 3 things I think would make the most difference. And actually, oddly, none of them are really directly to do with the structures of the NHS. The first thing is sorting out social care. And it's madness when you've got 1 in 7 hospital beds filled with someone who's well enough to go home. That's no way to run a functioning system, and it's not surprising productivity's been hit. I remember speaking to Stuart Rose, who was the head of Marks and Spencer's and then Asda, and he made the comparison with the supermarket. You know, that what matters is the flow of goods through the business. In a hospital, what matters is the flow of patients through the hospital. But at the moment, you've got this block at the end where the patients can't leave because there's no social care. It's impossible for that system to improve and have productivity. And the fact that the government is saying it may be 10 years before this could be sorted just seems to me like absolute madness. So that's the first thing. And I went to Denmark to see, and they've massively improved their hospitals. And what they do, actually, if there isn't a bed for a patient who's ready to be discharged from hospital, the local authority has to pay the cost of that hospital bed. Now, I don't think we could do that here yet because there isn't the capacity in the community, but it shows what the different incentives do, and they have virtually no delayed discharges. They just didn't understand the concept. That's the first thing. Second thing, similarly, you might think not relevant, but I would argue deeply relevant, tackle the obesity crisis. When the NHS is spending 6.5 billion a year on obesity now, that's due to rise to over 10 billion pounds a year. But yet, politicians of all parties run scared of taking action because they're worried about being accused of being the nanny state. It's particularly difficult now for Labour, even though I think Wes Streeting personally would like to do more to create a sort of healthier food environment, because they're worried that how that plays into the cost of living crisis. But at the moment, we've got this kind of obesogenic food environment where you've got a third of people, adults in England, are obese, 2/3 are overweight. And the NHS is picking up the consequences of that, not just in short-term episodes, but in these long-term conditions that are related to obesity. And I think unless you tackle that, you're never really going to have a system that's on a sustainable footing. Now, some people would say, there was a piece in the Wall Street Journal, I think it was last week, that said put Ozempic in the drinking water. Now, I mean, I'm nervous of the drugs because I think that's then a get-out clause for the food companies and for politicians and for individuals about actually the choices that we as a society make. And you look at countries like Japan that have brought the lowest obesity rates in the world by changing the food culture. You don't need to go to injections, although I think they obviously do work for some people. But that, I think, really taking that seriously is another absolutely foundational point for making the NHS more productive in the end. Because at the moment, if you like the social care, it's blocking it at the end. Obesity is creating all the problems at the front. So the system is malfunctioning at both ends. And the third thing, which both Caroline and Anita mentioned for me, is technology. And that is a total game changer. I was amazed last month, I think it was, there was a news story saying the NHS had done some deal with the Royal Mail to have a special stamp so that letters got through quickly. When you've got I mean, what is going on that's the priority rather than actually making this a completely digital system? And you've got 2 million appointments being missed a year because the letter doesn't arrive in time. Yeah. We did a poll for the Times Health Commission. I think it was 1 in 12 people said they or their family had missed an appointment because the letter either didn't arrive in time or arrived after the appointment in some cases. Yeah. This is just completely unsustainable. And the hospitals that have sort of used data more efficiently, better and effectively have improved the service dramatically. So it's Chelsea and Westminster Hospital cut its waiting list by 1/3 simply by joining up the databases from the different bits of its own hospital. Imagine if you then joined up with the GPs, and it also is much better at empowering patients, so they have some agency over their appointments. So data technology. I love the idea of the ambient note-taking. They're also using that in the police, which is driving massive efficiencies. So I think there's such great opportunities there that aren't being seized on. So that's the third leg of that for me. There was one other technology thing. I mean, just the basic hardware. When you've got consultants unable to cut and paste between different databases, so that you've got incredibly highly paid professionals retyping information into different computers, or taking 45 minutes to switch on their computer because it's so archaic. how can you have a productive system? No business would ever run like that. So I think investing in those basics is absolutely crucial as well.
Thank you. Helen.
Thank you. So I have both the advantage and disadvantage of coming last, but I think I do, looking at my notes, I think I do have some things to say that follow on from other panellists, largely all of which I agree with, but 1 or 2 points I will pick up. And I have 2 threes. I have 3 things that government should not do and 3 things that government should do. Now, the first thing that I think government could really not do if they want to improve productivity in the healthcare system, and this may be a lost cause, is not reorganise it every 5 minutes. So, I mean, Caroline and I were trainees together, so we've been in the service, what, about 33
million years?
Yeah.
Happy anniversary.
And I don't know if I've lost count. 10 reorganisations at least in that time. So, roughly every 3 years. They're mostly reshuffling the commissioning deck chairs. So there's actually been very little change in structural change in that time that actually touches the way in which services are organised. And one may well ask then actually what value that really adds. There is no perfect way to structure the NHS. Pick a structure and stick with it. And if we look internationally, and even if we look at the other 3 countries in the UK, we see more stable health systems making more progress that haven't been reorganised. Second point is not micromanage the how. There's a really important role for government to set the what. What is the offer? What can patients expect? What can staff expect in terms of outcome and experience? But actually the how, and this kind of picks up, I think, on some of Caroline's points on autonomy, the how really does need to be determined on the ground. There are lots of things that can be done from the centre to help people think about the how, but the circumstances, the way in which you're organising services in North West London, where Anita is, and the way in which you're organising services in the northwest of England, in Cumbria, where I grew up, they will be different. And that's not good, bad. That's about making sure that you are adapting to the circumstances. And you can't do that from the centre. I mean, Nigel Edwards, my old boss, reckoned that the English NHS is probably the most centralised health system in the world, with the possible exception of North Korea, and we don't really know anything about North Korea's. But, nowhere else centralises as much as we do. The third thing, and this is something that politicians, I think, are sadly very prone to do, the government should not do, is look for shiny new ideas at the expense of getting the basics right. So, other panellists have talked about the value of technology, and I'm absolutely with them. But it's not technology for technology's sake. It's about technology which actually helps clinicians to do their jobs better and patients to have a better experience of healthcare. And that leads me into the 3 things that government should do. And the first of those is support people to get the basics right. This is not about a great new idea. This is about people being able to access the care they need when they need it. And good administration and valuing good administration has a really significant part to play in that. So if I put myself back about 11 years, 10 or 11 years. It was when I was working in Monitor, and I used to spend quite a bit of time. People might remember that Jeremy Hunt used to run the NHS on Monday meetings. Yeah. So I used to spend quite a lot of my Monday mornings in Jeremy Hunt's office. And there was a point in that winter, 2014-15, when the Department of Health had found some winter money for the system, like as it does most years. And Jeremy was desperate for us to be able to say how many doctors and nurses this money had bought. And I was not brave enough then. I hope I would be now, but at that point I was not brave enough to say, actually, we would probably make more difference to the system and to staff experience and patient experience if we use this money to fund 50 good data analysts. Yeah. But of course, that's not what plays to the Daily Mail. And to the point about appointments processes, and actually, I'm going to take issue with you on the post thing, because actually that was something that National Voices pushed for, because not everybody accesses things digitally. But actually, getting your appointment systems right, getting your processes right so that people can access the care they need when they need it is a really important thing to do. My second thing is that they should do is get the money to the places that need it most. And that manifests in probably 3 ways. Anita and Rachel, in fact, have already talked about the need to invest in capital. We cannot expect hospital clinicians to be productive when they are literally working in buildings which are falling down. When your theatre roofs are being propped up, I won't name it because it's unfair, but it is one of the RAC hospitals. When you are working in a hospital where actually you can't use the theatres because they're being propped up, you can't use the theatres because every time it rains you've got to put buckets in to catch the raindrops, you're not going to be productive. You're not going to be productive if we're not investing in the IT systems. So getting capital investment right is something that government absolutely can do. And I think we're hearing some little noises about that today in the run-up to the review. The second thing Rachel has touched on, which is about investing in social care, is really important. I will, however, say it's not the be-all and end-all. And there's quite a lot of evidence when you look at what is stopping people being discharged from hospital, that a proportion is absolutely about the availability of social care, but a proportion is about how the NHS is connecting with itself and the flow through the hospitals to community services. And a proportion is what hospitals do themselves. So again, little personal anecdote. My mother was recently in hospital. She was admitted as an emergency. She was a nurse. We both reckon 3 nights maximum should have been her length of stay. 5, because she happened to be in over a weekend. And the specific physio they wanted her to see doesn't work at the weekends. And despite the fact that she had her community physio records on her app and she could show them, they wouldn't pay any attention to what was happening in the community. So there are things that can be done inside hospitals, inside health systems, and in social care. And just to pick up the point about funding, we've tried that. It's not that it couldn't work, but it doesn't work very well when your whole system's broke. And that's the experience that we've had. And my third and final thing then is measure what matters. And I quite liked Andy Orlowski's column in the HSJ recently. I don't know if people have seen that, which is on the premise that we've hit the buffers in terms of getting more money. So how do we get the best out of the money that we've got? He's got a nice little equation then in there which talks about value being the multiple of health outcomes and patient experience divided by cost. So it's not just about how many operations are we doing. It's about actually how you get greater value per input in the round, and how you measure that value in a meaningful way. And that goes well beyond the number of procedures that you're doing. It also plays into the wider economic impact of what the NHS can do for the wider economy. So, we know that there are a significant proportion of people who are economically inactive, some of whom are waiting for secondary care procedures, a lot of whom have musculoskeletal problems, a lot of whom have mental health issues. Those are not about operations and hospital activity. So we need to make sure that we're measuring productivity in the round, and that we're not just using quantitative data, numbers, but we're also looking at qualitative data. And we are talking to people, patients and staff, about their experience of healthcare and what the services can do to enable them to live more productive lives, whether they are staff in the NHS delivering productivity for the healthcare system, or people who are participating in their community economically, working, volunteering, adding value to their families.
Thank you. I'm just going to ask a few questions before opening it up to the audience. Caroline, you talked about unwarranted variation, and there are clearly some trusts that are performing better than others. In your view, what are the key enablers? What is it that those high-performing trusts have that the lower-performing trusts don't have?
So, first thing, really great clinical engagement. So, if I think through the work that we did at the Royal Free in North London, where we had a number of hospitals. And we were very intentional about this. So we worked with Intermountain, who are a group of 21 hospitals in the US, and they have great cost and quality metrics, have done for 30 years. So it wasn't about digital transformation. It was about how do they work with their clinicians. There's something about giving clinicians the data, giving them the wherewithal to work out which groups of the patients that they're seeing do they want to influence most. And then at the Free, we use technology to actually embed kind of best practice processes into our kind of digital pathways. It doesn't have to be like that. Intermountain did it on kind of spreadsheets and bits of paper for years and years and years. So I think there's something for me about, trust the people who are looking after the population. I think in 2025, if we're going to do it again, you'd want to do it across the whole patient pathway. Because, of course, most of what happens to me as a patient doesn't happen to me in hospital. It happens to me either at home or in general practice or out of hospital. So you've got to kind of do a bit of a kind of left switch. But I think for me, it's, sometimes variation is warranted. We talked about, getting money to the right populations and making sure that, I think you said Cumbria and North West London are very different. So that's absolutely right. What you'll have a sort of non-standard approach. But for many, many clinical processes, a level of standardisation is warranted. And we now have the technology to be able to do something about it. But you've got to let your clinicians lead it and enable them to do it.
Anita, you said there are kind of different ways to incentivise the system. Different countries do it in different ways, but what's really important is that you have clarity of purpose and consistency. How clear and consistent do you think the approach taken by the new Labour government is?
Well, we don't know at the moment, and that's what the 10-year plan is about. I think one of the things that we need to have a really close eye on, though, as that comes out, is the extent to which it is a repeat of the 2000s playbook, or is really fit for purpose in addressing this question of the left shift. So in the 2000s, the system that was put in place was very effective at incentivising hospitals to improve their efficiency. But what it did was focus very much on an incentive framework for hospitals, but then we gave block budgets to community health services and to mental health. We have very little measurement of activity, outcomes, understanding of best practice in those, and very little join up. And a lot of our best talent was focused towards the hospital, not towards the commissioning. And the fact that we constantly rearrange the commissioning and the out-of-hospital system makes it harder to attract that talent. So in this, and we've had, therefore, every few years, alongside a reorganisation, a restatement of the need to shift left, to move from hospitals towards prevention and upstream into the community. And cognitive dissonance, as the money always goes, and the people and the talent go in the opposite direction. So for me, the test is less what it says about the hospital and what it says there, and the extent to which they tackle and really think through how you get the incentives and the leadership to cross the organisational boundary to look at the whole flow. And that's really hard. So I think that's the really important test.
And Helen, I was going to ask you, because you talked about the importance of having the right measures. How problematic do you think it is that the government has chosen the 18-week elective target as its milestone? And what would you want to see in the 10-year plan? What would be the better headline metrics that the government could be?
So I think it was a very interesting decision. Because at one level, it's an easy one to measure. We know how many people on the waiting list. We know we can count people in beds. We can count operations. But actually, if you want to pick something that's going to resonate with significantly more voters, it's getting primary care right. And I am genuinely slightly puzzled why he decided to pick on the 18-week target rather than a similarly easy to measure, also easy to, relatively easy, to manipulate and with unintended consequences, which is better access to primary care. So again, people may remember back in the Blair years, there was kind of an overnight policy shift after Blair had been on breakfast television or something, which was setting the 24 or 48-hour target for people to be able to get an appointment with a GP, not necessarily their GP. And actually, notwithstanding that quite a lot of money was chucked at it, we achieved that. And people were very, very happy with their primary care services, although they did grumble, rightly, that being able to get an appointment with the GP within 48 hours meant that they couldn't get a planned appointment if they wanted one in 2 weeks' time. So, you do need to think about the unintended consequences. But I do think it is problematic because it misses all the things that we've been talking about in terms of what's happening across the wider system. If he wanted to pick a hospital target, I'm not, Caroline's a hospital person, I'm not a hospital person, but the one I would pick is the 4-hour A&E standard, because that is the one that, if you really think about it properly, and don't just measure it in the hospital, that is the one that shows you how your whole system is working and whether you're able to get the flow through the hospital that Rachel referred to.
Rachel, we talked a bit about kind of accountability and autonomy, about how centralised or not our system is. How much of a centraliser do you think Wes Streeting is? And is that coming from him, or is there a wider kind of philosophy of public service reform across the government, or is it sort of each Secretary of State to their own?
It's a really good question. I think in a way all health secretaries are at least tempted to be centralisers because they want to pull the lever that's going to make a difference, because they know their head's on the block if they don't. So there is a temptation always to set targets that you feel you can control and that you will then be judged on by the electorate. I think what he is the most overt, if you like, performative reformer. He is absolutely out there with his chainsaw or whatever in a sort of, not exactly Muskian, but he is really demonstratively going out to show he wants things to change. If you compare to some of the other people around the cabinet table, you know, say Bridget Phillipson in education, she's far less kind of combative about it. Shabana Mahmood, I think, is a really interesting, it's almost like, if you think of it as Goldilocks, if he's the sort of on the hot side, Bridget's on the cold, Shabana's in the middle, because she did that really quite radical sentencing review set of reforms, but having rolled the pitch very carefully and without managing to somehow take with her quite a lot of the stakeholders. Whereas I think deliberately Wes has gone out there to say things have got to change and almost reflect the frustration of patients, whether that's about GP appointments or waiting lists. It's partly to do with personal style and politics, but in the end they'll be judged on whether it makes the difference.
I'm going to open up to questions from the audience. I'm going to take a few questions at a time. Can you please wait till the microphone gets to you? Please say your name and where you're from. And please, please, please make sure they are, in fact, questions and not long, rambling statements. I will take one here, here and here.
Hello, Henry Anderson, HSJ. I wanted to ask a question about data because everyone seems to think agrees it's important. But if you're, I don't know, in say West Yorkshire, for example, the organisation that has sight of the kind of flow between the different trusts and patient outcomes is the ICB, and the ICBs are being cut very heavily. Nationally, you've got NHS England, and that's being abolished. So I wanted to get the panel's thoughts on how, what the scale of the risk is to that, and whether, reorganising the organisations that are sort of have that system oversight is really the wise first step to take.
Thank you.
Hi, thank you for that. My name is Stephen Walford. I'm a GP registrar and an NHR academic clinical fellow at City St George's. I'm a bit biased, but I'm just wondering what your views are about funding into general practice, especially considering how old or antiquated the Cahill formula is now, whether that's still fit for purpose, and also more broadly about the partnership model and whether that is still a sustainable model for funding for general practice. And then finally, what would be the implications if it's left shift ultimately for hospital services, because money has to come from somewhere, and if we are thinking about secretary to primary care, that's going to have implications.
Thank you.
Hello, Andy Cowper from Health Policy Insight. Agreeing completely with Helen's point about the 18-week referral to treatment target being the main focus, it is, however, their manifesto commitment. So given that it must be delivered, how are the other priorities, which all the panel have rightly outlined, going to get their moment in the sun?
Great, so three great questions. How is the government going to deliver all its other priorities if it's also delivering the 18-week target? Question on GP funding, future of the partnership model and implications of the left shift for hospitals. And the final question about the scale of the risk from the cutting of ICBs and NHS England for system oversight. Can I start with you first? I'm going to start with Helen first this time.
Great, thank you. Thanks. So, what order? So let's take Andy's question first. I mean, the obvious theoretical answer is the 10-year plan. We're all waiting for the 10-year plan. The 10-year plan's going to set the new priorities. We shall see. When we were chatting beforehand, I was saying, I was on one of the working groups for the 10-year plan. I think it's going to be very genuinely, I'm not being cynical, I'm being a little bit cynical, but not very, genuinely interesting to see how the many authors of the 10-year plan properly take account of the very wide public consultation that was undertaken, and also the outputs from the 10 working groups which were set up for it. But they, all the mood music is very much about that plan having some clear priorities which are about moving the system from being a hospital-centric system to being a community and person-centric system, and you ought to be able to hang some policy and performance priorities off that. And I think that probably also then connects to the other two questions. I mean, I think the ICB question, I think one of the things that's interesting about data is, particularly now, is that you can make it really transparent. Anybody can look at it. And I think there's something that we need to see how it works out, and probably will work out different in different places, about the relationship between the ICB on a bigger footprint and place. And there's something about actually how places use data to drive how they work with their people work with their communities, and what kind of systems and services are available in a place. That almost doesn't matter how big the ICB footprint is. And transparency of data means that people at any level in the system can challenge it. So I mean, if I go back in, again, I don't know, 15 years, we pioneered in the system I was then working in having real-time data to inform our urgent care system. And actually, anybody in the system being able to see instantly what was happening. And I remember Chief Executive of one of the hospitals ringing me up at the weekend and saying, the community provider hasn't done X, and can you sort it out? So I had a look, and I had a word with the community provider, and I went back to him and said, yeah, I have had a word with them. But actually, you're not doing Y. And I could say that because the data was transparent to all of us. Yeah. And finally, then, on the general practice model, I mean, I think we are looking at a new GP contract. We don't quite know what it's going to say. It will drive the way that general practice works. I am not sure, and I'm genuinely not sure, will it genuinely change the ownership model. I think it will change scale. So if I think back to the 2006, 5, 6 GP contract, that was really the death knell for the single-handed practice. And I think whatever contract form we look at now, we're going to be looking at general practice working on a bigger scale, whether that's bigger partnerships of partnerships, whether it's about trusts taking on GPs. And you know, I don't think it necessarily matters what the organisational form is, as long as what's in place in a local place works for that place.
Yeah, got it. Rachel.
Yeah, I wanted to pick up on the data question, because I think actually this is the most interesting thing for the government now that it's facing, and how you use data, not just within the NHS or the health system, but across the public services. And if there's one way that the government can sort of square this circle of not having any money, it's by driving efficiencies through data. And that's how you also simultaneously can improve the performance for people. So there's a really good example in Bradford, the Born in Bradford project, where they've taken a cohort of children, babies born, they're now in their teens, I think, and they've looked at the data across all bits of the public sector related to these children with the permission of their parents. So many interesting things have come out of it. So one example, they took the health data and found out which children had eyesight problems. And then they then realised that a lot of those children weren't going to get glasses. So they arranged for the children to get glasses. So they then cross-checked with the literacy data, and they found out that simply by giving the children a pair of glasses in the classroom, as well as a pair of glasses at home, literacy rates improved by, I think it was 17% in, just a couple of years. So these children couldn't see the system by comparing the sets of data that already existed for the government, have managed to dramatically improve the outcomes for those children. I saw it in the police as well. Bedfordshire Police have they've introduced a sort of AI model that takes data when they're doing an investigation from multiple sort of platforms, including the suspect's mobile phones, but then also CCTV footage, or it could be national database, national police computer, all of these things. It mashes it up and then produces a suspect profile, or it produces, it extracts the relevant data from multiple platforms and public services. And you then end up slashes the amount of time it takes for the police to investigate with better outcomes. And it's making connections that would never have been never been possible for a human detective. So I think, and this then leads into the whole question about, do you have digital ID cards? How much does the government use this as a sort of positive thing about enabling the citizen, and then the citizen having power over their own data and having power over which bit of the government can use it. So in Estonia, for example, you have a digital ID card from birth, and if you want to, you can opt out of a particular clinician having access to your data, but it'll warn you that your healthcare may be harmed as a result of your choice to opt out of the data sharing. So I think it's the most interesting sort of new frontier of public service reform, with huge potential and obviously huge ethical dilemmas too. And I think the government hasn't completely resolved where they stand on it.
Anita.
I'm going to link the data point with the ICB and NHS England cuts, because I mean, the amount of time that is spent at the moment, to pick up on one of Helen's points, arguing about the data and what's actually happening, and the amount of time also that is spent on fairly basic transactional activities, which could be much more efficient and effective if they were redesigned and supported by data. Those two things, I think, if we get right, and we really do make sure there is one version of the truth across not just the NHS, which would be a challenge enough, but also with local government and other partners, that would be huge. And a lot of the really basic transactional activity, we do mechanise and we focus on, therefore, having skilled professionals who are looking at the information and intelligence and making the judgments and doing the human interface about what to do about that. Getting that right will make an enormous difference to what these cuts to ICBs and the abolition of NHS England and this new form will take. But we also needed that because the system is one of the things I think that is happening here, and it links into the GP point, is what sort of data as well. So we're obviously moving to this idea of neighbourhood health, which has GP services, most of which now are not delivered by a GP. Yeah, so GPs are in the minority of the workforce in general practice services, and when you add in all these new, what they called R's, additional roles as well, that's truly the case. So GPs are part of the multidisciplinary team. Some of those are wrapped around general practice, others in neighbourhood health. We want to bring in a line, so social care, community services, school services, some of the prevention services, school, district nurses, health visiting, all of that sort of thing. It is being very clear then, I think, and having the data on actually what good looks like and what outcomes are being achieved across the piece. And my worry is less about, is the partnership model per se the right thing, but actually how do we get a structure in which all those different organisations and the employers of all those different workers genuinely share responsibility and accountability for a patient and can agree together that this person is going to see that patient instead of that person and move the resources without it having to go up and have a national contract renegotiation to do that. And that is one of the challenges. And then do we all share a sense of what a successful outcome looks like that moves away just from activity? And I think, again, this is where the world does feel very different to 20 years ago, and patient-reported outcome measures in the jargon, patient-reported experience measures. We need to be putting more of these things into the system. We did a load of work on mental health with the University of York and others a few years ago. We started out that work looking at the efficiency of mental health providers. And we started out that work by doing a load of sessions with users of severe mental health services and asked them, well, what constitutes a good service? And what they said constituted a good service was completely absent from the things that we measure. And that seems a really important thing to fix. So it's great to have data, but you do need to have the right data.
Yeah,
Go on.
very good. Okay, so I want to massively agree with Helen and Anita on the need for scale in general practice. Some of the best general practice in London exists because those practices have been more heavily invested in. They're part of a bigger group, not necessarily a big, US-owned group, but often an NHS group. And the clinicians in them, be they GPs or not, are sharing and their morale is higher. So I think scale really matters. I think this thing about organisational form is really interesting in general practice. I don't know what the answer is. I feel a bit neutral, but I do think that we're left with a real tension. How do we get particularly hospitals and community organisations to invest in the integrated neighbourhood teams that Anita's just described? If you want something good to read, London published our version of what we think a good model for integrated neighbourhood working could be across the capital. It's not too prescriptive. We've done it with loads and loads of stakeholders, and I think it gives us a clue as to what's going to be in the 10-year plan as well. But that's really important for us. Getting that right will help a lot of these other issues get resolved. On data, I think scale is also important. So to your point, I think ICBs will lean in more and more. And I think some of this is about, actually, do we have the capability to use all this data? So for me, you have to put people together in order for them to get skilled and to be able to interrogate and analyse. And then you have to train people like me in actually what the right questions are. And, we grew up in an analogue world, didn't we? So, we did. This is new for lots of us. And one of the best, I get to meet the chief execs and the chairs in London once a month. And some of the best, there's meetings when everyone leans forward because they're kind of like, oh, that's amazing. So we did it with ambient note-taking. We had some kind of software that we showed people. We've done it with the federated data platform where we've showed people kind of actually what's on offer. And to your question, Henry, I think the FDP actually should be part of that solution because it will allow us to do some of the joining up that you were describing. Andy, to your point about other priorities, well, it's a 10-year plan, isn't it? So some of this is about timescale and stretch, I think. In London, we've been quite brutal about having to stop doing some of the things that we thought were really important because we just don't have the resources to do them. So we've been quite clear. We've got 6 priorities in London. Some of them are about how do we deliver some of those constitutional standards. Some of them are around mental health because the capital's mental health services, particularly out of hospital mental health services, aren't good enough. We have one priority on cardiovascular prevention where we say across the capital we're going to do more work together because we can see that for 10 million people there's some really strong messaging. And then the rest of our priorities are actually about digital and tech and how do we bring tech to bear on some of the operational standards. So, for example, if you have a mole, there is now technology where you can, by the end of this year, you'll be able to use your iPhone, take a picture of your mole, get it diagnosed. You need never go near a GP or a dermatologist because most of us will have a benign mole and the technology exists. And we just need to invest in some of those things up front quickly, which will then kind of sort of take the edge off some of the big constitutional standards. So I think we have to be better at prioritising. It's like any public service, we've got a finite pot of money, and that's what we need to do next.
Can I just pick up quickly on that tech point? Because I think the broad history of medical developments in the NHS is that they deliver better outcomes but tend to cost quite a lot more.
Yeah.
Do we think that the new tech developments coming down the lines will break that cycle, better outcomes but for a lower price as well?
I think it's what I said before, it's not going to happen by magic. So you've got to be really intentional and you've got to target the benefits and you have to bring it in for good reason and then everybody has to be aligned about that. So every time, I mean, the current narrative around electronic patient record systems is they've all cost more money, isn't it? And therefore, why is that? Doesn't seem right. Actually, they shouldn't, and we need to use them to the best of their functionality, and often we've put them in without doing that. And I can remember putting in a well-known American system into one of our hospitals, and I can remember the nurses all just writing bits of paper, and as we were implementing it, they were just writing everything down rather than sticking it on the screen, because that's what they were used to. And the cycle of technological change takes a lot longer than we think. We've got to put some of the big US companies on the hook for helping us do this better, because other places do it better. So I think there's a bit more to it than just us.
So one of the things that you see with the technology is it really should reduce the unit cost of many of the things that we're doing if we adopt it well, yeah? And to Helen's point before about where we invest, to adopt it well, we need to buy the kit, yeah, obviously, but actually we need to spend on the deployment of the kit and the training. And one of the things that colleagues in HSJ have leaked on good authority, I think, from the 10-year plan is this idea of, at the moment, this is the Institute for Government, so I can be geeky. At the moment, obviously, we have a resource budget and a capital budget. And the capital budget is ring-fenced, CDEL in the jargon, and that's really important. But an awful lot of actually the IT investment is not the capital budget, it's the resource budget. And we just did some work with PA Consulting, sort of estimating the cost of digitising the NHS. And there is a classic kit cost, but the bigger cost actually is the resource cost. So there is if the HSJ are correct, and they have a pretty good track record, and the idea of creating a category of a digital DEL to try to protect that and so spend that is really important. I want a prevention DEL as well as the other form. I think we need to be much smarter about what we consider to be the investment spend and much less old-fashioned. Our view of investment is about 30, 40 years out of date. I'd like that as well. But the thing that is difficult is that what the technology tends to do is, even if you deploy it really well, which would be great, is it also often expands demand. And I think one of the things that's quite interesting is in the UK, we have historically had, and when anyone looks at our health system, they say that's brilliant, we've had NICE as a process of determining what medicines should and what new technologies should be adopted in the NHS. And we have a screening committee as well, which runs a similar process to understand what's cost-effective screening. Some of these new technologies make that quite challenging, I think, and we've not allowed, for example, historically direct-to-consumer advertising of pharmaceuticals, which in the US they do. It's really interesting to see what's going on. The weight loss drugs are proving quite a challenge to this model. Some of these new technologies, I'm not quite sure how we're going to control. If I get some of, people are doing these 4D scans of their babies and no one quite knows what to do with that, so they pitch, or they get a genetic profile, they pitch up their GP and go, look what I've got, what should I do, and so, and of course a lot of these technologies, like people now being able to go and get their MRI scan or things like that, the actual cost of the diagnostic bit, the screening bit, is really cheap, so people pay out of pocket. You don't need private health insurance. Lots of people can afford to pay out of pocket. But then what they do is come into the NHS. And what do you do in the NHS? Do you just can you just say to people, well, you did that privately, we're not seeing you?
Just one other thing is, I think, really fascinating. We're in this incredible new age of cures with medicines being able to not just treat conditions and illnesses, but actually cure them genetically or through different methods. But we've got a system that isn't set up to deal with that. So if you cure someone, they have then a lifetime of earning, but the system operates only on the sort of annual cost. So I think the NICE has to rethink how they measure the benefit. And I think it's really interesting, your point, Anita, about the Treasury has to think much more about the long-term benefits of policies rather than just the 3-year cycle. They sort of relate to one another, those 2 points.
So we've had a question related to this that I was going to put to you, Helen, actually, online from Grace Duffy, who says that siloed annual budgets are driving poor outcomes as well as bad value for money. What is stopping the NHS spending money more effectively by pooling budgets and commissioning services for longer?
Oh, I think Caroline's probably had some similar experience to me. I spent quite a lot of my career pooling budgets, and it has many benefits. There are some interesting challenges, and it depends whether you're talking about pooling budgets within the NHS or between the NHS and particularly local authorities. So within the NHS, to be honest, what gets in the way is, how should I put this, organisational ego. Because there is nothing legally, statutorily, that stops NHS organisations pooling their budgets to work differently. But there is a very, maybe it's too cynical to say it's organisational ego. It's also about where performance gets measured and what people are held to account for. Because if people perceive that if they pool money, there is a risk that the thing that they are held to account for will not happen, then they will be anxious about doing that. So you've got to find a way of getting people to a win-win on that. Pooling with local authorities, and we've had the Better Care Fund for some years now, but actually we've been working on pool budgets for, or since I was a trainee, so we're going back 25 years. There are some real practical challenges that get in the way, like things like the VAT regimes and the charging regimes. So actually, how do you work across health and social care boundaries when an NHS, the cliche one is an NHS bath is free, but a social care bath is charged for. So when you're pooling budgets, you've got to work through all of those things. And I had a third point which has completely gone out of my head, so perhaps somebody else will want to.
Caroline, do you briefly want to come in on?
Well, I spent in my mid-20s, I spent my time pooling learning difficulty and mental health budgets in Camden and Islington, which all then got unravelled because of exactly the reasons you're saying. So I still think the more that we can align the financial regimes of social and health care, the more we'll get to some of this. So in my current job, I spend a lot of time refereeing between local government and organisations like yours around the Better Care Fund, which I think has actually exacerbated some of the silos. So perhaps in my manifesto, number 5 thing could be actually, can we start again and start something, a different regime that actually starts to align our incentives? And government can do something about that. So.
Sadly, on that note, I'm going to have to bring this discussion to an end. Thank you very much to our 4 fantastic speakers, to the Health Foundation for partnering with us on this event, and to all of those who have watched live or have listened back later. Thank you.